This can be used for facial dermatitis. So we already said we wanted to avoid putting steroids on the face. And then patients that are intolerant of steroids, if they failed steroid therapy prior, or if they're not responsive to other therapies, then we could try an immunosuppressive regimen. The mechanism of action of the immunosuppressives is that they act on T cells by suppressing cytokine transcription, and most commonly uses the calcineurin inhibitors like tacrolimus. So the dosing is twice daily until lesions are cleared, followed by an additional 7 days. And so it's not the same for everybody. It's going to be prescribed based on the patient's response. So these should not be used under occlusive dressing, and there are extensive drug interactions with the 3A4 drugs. So this is a substrate for 3A4. Have you guys talked about drug interactions at all? You know what you're familiar with 3A4 and some of the drugs that interact with that? What's the drug that interacts with 3A4? Coumadin? Good try. Coumadin interacts with some of the cytochrome enzymes, but not 3A4 as much. Good try though. I appreciate that. What? There's a long list, like penicillin, rifampin, all the azole, antifungal. So if you think someone that has like contact dermatitis might be on an antifungal, maybe it's a fungal type thing. So, but penicillin and rifampin are huge ones. They can cause a lot of problems because they're inducers, and so they can like speed up the metabolism. And so this is a substrate, so it is broken down by this enzyme. Because if you give an inducer, it breaks it down faster, and so then you're getting less of an effect. I took an entire course on this, so I don't expect you guys to know or remember the drugs, but no, I appreciate your participation. You can shout out whatever you want. I'll just be happy to do it. I still don't remember them all, but that's why we have technology. My computer tells me what interactions I put in order to do. So some of the adverse effects are burning and itching, which can diminish with continued use. So the patient complains of this. If it's not that severe, then you can talk to them that this might go away with continued use. If it's very severe, then you might need to change to an alternative treatment. And then ingestion of ethanol may cause flushing and redness with this medication, so you would talk to them to avoid excessive alcohol intake. And then photosensitivity can also occur, and it's actually very common, and so you would want to tell them to stay out of the sun, use sunscreen whenever you're going out, even if it's just for a short period of time, even like 2 minutes, can cause a sunburn. All right, so systemic corticosteroids. So we're talking now about like oral prednisone, anything IV like methylprednisolone. So these are used for severe acute exacerbations. And again, mechanism of action list is huge. You don't need to memorize that. These again are only going to be used for acute severe exacerbations, and that's like the major point here. So we're not going to be giving everyone oral steroids because there's a lot of side effects. And so we want to try to treat topically. If this is a topical issue, we want to treat topically if we can. So that kind of takes us. So same reason why we treat asthma and COPD with inhalers when we can, and then when they have an exacerbation, we'll give them like a steroid, sometimes antibiotics, systemic therapy, but for treatment of their complications. But in the meantime, we'll keep them on inhalers for topical therapy. So for the dosing for the systemic steroids, we want to taper them over 2 to 4 weeks. Less than 2 weeks can cause a rebound in the dermatitis. So with steroids in general, I don't know how much you've learned about steroids, but depends on who you ask, pharmacist or provider. They kind of have a different cutoff as far as like how long a patient needs to be on steroids before they need to be tapered. But I've usually heard anywhere between 7 days and a week, or 7 days and 2 weeks. And so if a patient's on high-dose steroids for over a week, we usually recommend for them to taper. But definitely if they're on steroids for, especially high-dose for 2 weeks, then they need to taper for sure. And so we want to make sure that we're taking them off slowly. And so if we're going to be treating them for 2 to 4 weeks, then we definitely need to taper them.
So if you're going to taper over 2 to 4 weeks, a Medrol dose pack is not going to be really appropriate to treat dermatitis?
It kind of, I mean, I would say no. I'm sure that it happens all the time. But a Medrol dose pack is like 6 days. So I don't know. I don't prescribe or verify Medrol dose packs a lot because we don't use those inpatient. And I don't work outpatient, but I think it's like 6 days. I mean, they can do whatever they want with them, but the standard ones are fairly short. So that would probably not be appropriate. If you're thinking 6 days, then is it really something that they need to treat systemically? Or is that a topical thing? But I bet in real life it happens. So, good question. So drug interactions, again, a lot of these same like CA4 type medications, barbiturates, hydroxypenicillin, that's like penicillin, phospenicillin, and rifampin can decrease effects because they increase the metabolism. They decrease the effect. There's contraindications with systemic corticosteroids, such as active infections, such as TB, or if they have chronic comorbidity. What do steroids do with patients with diabetes? Increase blood sugar, exactly. Hypertension. What does it do to your blood pressure? Increase your blood pressure. So basically, it gets your body all out of whack. And so it's not necessarily a contraindication for a patient with diabetes to be put on steroids, but it is necessary that you tell a patient that has diabetes that they might need to use more of their insulin, that they might, they need to be checking their blood sugar more often. Because I've seen a lot of patients come into the ED with excessively high blood sugar, and then we find out that they were just put on steroids, and that's it. And so we can treat them, and they really didn't need an ER visit for that, but they weren't informed of that, and so it can mess with a lot of the patient's comorbidity. It's just something to be aware of, what these medications can do for the other things that are going on with that patient. So it can mask infections. That's one reason why we're talking about not giving steroids to patients with other infections. And it can also cause GI upset, so we tell these patients to take it with food. We also tell them to take it in the morning because it can cause sleep disturbances, especially in children. And so a lot of times when we have twice daily dosing of steroids for children, we tell them to take it like in the morning and then as early in the afternoon, evening as possible, or else it'll be up all night. And then it can cause mood changes as well. So antihistamine, the primary role is really to alleviate itching. It's not really going to help with dermatitis, but it's going to alleviate the itching that's associated. So it blocks the histamine receptor site. It's not going to block the release of histamine. It's just going to block the histamine from binding to the receptor. So there's two different types of histamine blockers, ACE1 and ACE2. And then first generation are sedating. Those are diphenhydramine, promethazine, chlorpheniramine. And then second generation is more of like loratadine. Those sorts of like non-sedating transients. Not going to test you on that. So for selecting appropriate therapy, we kind of talked about this already. The topical corticosteroids, slow to intermediate potency twice daily. If no improvement, we want to increase the potency, but not the length of therapy. Occlusive dressings and moisturizing skin can be helpful acutely, and then So again, we do this repeatedly to get the symptoms under control, and then we can remove those if we're dressing no more than 12 hours at a time. And then oral antihistamines can be used to help with dosing. And then second line, you can use more potent steroids, topical immunosuppressants if they're refractory to steroids. And then third line, systemic steroids. And I don't know why it says take it over 2 to 3 weeks, because we talked about 2 to 4 weeks before. 4 weeks. You can correct that if you wish. I'm not going to text you on that. But just to be consistent. So for pediatric patients, we'll use a 7-day maximum. I told you this is different from the adult population where we use it for 2 weeks. We'll do 7-day maximum for kids for topical corticosteroids at the lowest potency available. We'll start low, go slow for the 2 week patient for up to a week, and then we can increase potency if needed for the each patient. For the immunosuppressants, we're only going to use these in the patients 2 years of age and older. And then for geriatrics, so the other end of the spectrum here, we first want to think about why are they having this contact dermatitis. So a lot of times it's caused by other topical medications. So anyone ever looked in like their grandma's medicine cabinet? They have like so many meds and they have like a lot of creams and ointments and everything. And so it could be caused by something else, something that they already have, or something that they're exposed to. And so they might not present the usual fashion either. Their skin may appear more scaly rather than having more of like the vesicle pattern that I can get that with in the bigger population. And then topical steroids, we want to kind of be a little hesitant with prescribing because it may cause skin atrophy, which can be a problem in the elderly population with their skin already being frail. So again, if you wanted to start at a lower dose and then increase the potency if needed. So patient counseling, one of the obvious points is avoid the irritant that caused this. And then with the topical corticosteroids, you want to make sure you keep the skin moisturized because this helps the penetration of the drug. And then demonstrate the use of assisted dressings if it's an outpatient use. So they can use plastic wrap, and then you would cover that obviously with like a sock if it's like a leg. Or they can use like a shower cap if it's something that's on their head to keep that area locked in with the moisture. And then with immunosuppressants, we talked about avoiding assisted dressing, alcohol, and then keep away from sun exposure, wear a hat, wear long sleeves and pants, and then use sunblock if they're running out as well. Alright, so that's it for contact dermatitis. Do you guys have any questions? See that kind of fast, but it's pretty straightforward as far as that information. Alright, we'll go through the least part of fungal infections and we'll take a little break. We're doing good on time, right? Let's get out of here. You had your test this morning? I hated test days. I know, it's my, yeah. I didn't write it, so I'm going to stay out of that. None of you guys did. Carl wrote it. I'm going to blame Carl for everything. All of the instructors are useful. Like, I'll write the questions for the next one. I've had, like, last year when I taught and wrote questions, like, I had a couple of questions come back after the test because there was confusion on them. And so I believe questions were thrown out because of confusion. So, but they emailed me and like we talked about it. And so, and I believe they were like 2 questions and mine was thrown out last year. So I don't think like, I mean, I didn't think I had any say in throwing them out, but I didn't care. Like I was like, oh yeah, that's fine. I can see where there's confusion. So I asked the lecturers to send me 15 questions, and then so we pick 10 of those questions so that we have some to choose from, and then we send y'all the continued exam. And so I don't know, we never asked then ask to rewrite. But if there are questions that are, I mean, they look over it and see, half the class got it wrong, then they might throw it out. So I wouldn't worry too much about that. Like if there's a bad question, then it will be used. Because it's happened in the past. So, yeah. I mean, they shouldn't overrule us if they wish. So, do you want them to write the text question?
No.
Okay. I hope it wasn't me. I can follow up on that. I don't know if you guys, if you have specific issues, if you can email your past president. All right, we can talk after class. I do have to go to work after this. I get paid. All right, what are we on? On one section. All right, skin, hair, and nails. So, tinea is caused by a dermatophyte. So this is a group of fungi that infect non-viable keratinized cutaneous tissues, causing dermatophyte. I can't pronounce half the words in this section, by the way, because they're long. So we just say tinea. So tinea. And so it's further classified by location. So it's the same causative agent, but based on where it's at, it's going to be called something else. And so you can do that for your reference. Where it's at, again, is what it's called. And so what are the causes? Warm, moist, acidic environments kind of breed this sort of infection. I don't really understand why a family history can lead you to be more predisposed for this, unless it's like close quarters with someone like that. But apparently that's a cause of this. A compromised immune system, which seems pretty obvious, and then infections can be spread person to person. So that's what I was getting at with family history, and then by animals or termites. And then, so the pathophysiology, dermatophytes grow only within keratinized structures. These are dead cells. So that's why it can infect your hair, skin, and nails. And so this is like a part of your skin that's dead already. It doesn't have a nucleus. It's going to be like your top layers. And they produce enzymes that allow them to digest the keratin. And this causes scaling of the epidermal layer and or thickening or crumbling of the nails as they're lost. So tinea capitis, this is your head, primarily affects children ages 3 to 9, especially African Americans. And this has a 15% cross infection with tinea corporis. So if we go back, tinea corporis is from the body, so that can be like anywhere on your body. It can be like some, I've seen them like on the neck, and you can see how that's associated with the head, or even just anywhere on like the arms as well. So it can be generalized diffuse seborrheic dermatitis, like scalp scaling. It can be inflamed or scaly or have alopecia patches. So what is alopecia? Hair loss, exactly. So you'll have like, especially on like younger kids that don't have much hair at all, they'll have like areas, patchy areas with like no hair. So that's pretty classic. presentation for these kids. And a lot of times these kids will come in for something else. We got a kid a couple weeks ago, came in, he had otitis, like really bad otitis. And so we were in there helping on this patient, and we were like, anyone notice the thingy on his head? So we were in there for something else, and he had really bad thingy on his head. So we had these like bald spots as well. So we were able to treat for that as well. But they might come in for something else. So just kind of looking over all of the symptoms. So they can have diffuse swelling, the alopecia secondary to like broken hair shafts. So again, this can affect the hair. That's the dead cell hair size. You can have gray, patchy type areas with scaly plaques. Again, the alopecia, the hair loss. So it can present like in very similar but different ways. Or it can have tender pustular nodules. There's some pictures here of kind of how this can present. It can have these like tender, like pustular like nodules, or just like that gray patchy areas, or just areas with alopecia as well. Then, as we talked about, there can be a corporate. So this can be transmitted person to person. Can be from infected animals or surfaces. So we hear about like in high school, like a lot of wrestlers, men's wrestling teams, which will go around if it's on the mat, so that's like a warm, like environment. It will present as a ring-shaped lesion with well demarcated margins, which can be very nice, circular bullseye. And it can be scaly or erythematous border. Can be a furus, which I can't pronounce very well. There's some R's in there. This has like a hallmark itchy or burning sensation, and the borders are well demarcated and peripherally spreading. So this has a large erythematous or macular lesion with a central clearing. It usually spares the scrotum, so it's just like in that joint area, and it's often accompanied by a fungal infection of this. If you have a patient that presents with this, usually ask them to take off their shoes and socks and look at their feet to see if they have that fungal infection as well. So as we talked about, ask them to take off their shoes and socks. Peniatritis is usually in between the toes, and this is scaling. And it usually presents with fissures, so it might not look like the scaly on the left side, but it can just be like the cracked, like red cracked fissures. So a lot of patients we have in the hospital that come in and they have like a cellulitis of the leg, and then we'll look at their feet and they'll have a fungal infection in their feet. And so that's usually how they get the cellulitis, the bacterial infection within their legs, is that it enters into their feet, which has a fungal infection. So we usually treat the bacterial infection systemically, the antibiotics, and then we'll treat topically for their fungal infection on their feet. They can have, this can be more than just in between the toes. It can be on the soles, on the bottom of their feet too, and then it can also be like this in the, like a testicle or be like in the sole of their foot, like by the green towards their feet and stuff. So it can present in a lot of different ways. This is a lot more rare. You can see it. Alright, so I'm barely talking. So tinea manis, or fungal infection in the hand, is always associated with infection of the feet. It is usually unilateral, it's usually on one hand or the other. As you can see in these pictures, like this hand's infected, this is not, so I'm not really sure why it presents like that, but it usually is presenting unilaterally. Usually mild, diffuse scaling of the palmar skin, usually on the palms and upper dorsal side of the skin. And then vesicles can be present, and they can be bruised on the palms or the fingernails can be involved as well. Anyone want to go for that one? Exactly. I can't pronounce it. Also called osteomycosis. This is where you have the infection of the nail. Males become thick and scaly with subungual debris. So it's usually like a yellowish discoloration. You have like striations in the male. And you'll see it like clearly demarcated on the males. And the substance accumulates and kind of lifts up the male away from the male bed. And it begins usually distally at the tip and then moves proximally through the male to the end of the male plate. And it can be asymptomatic, like it's not painful at the onset, but it can increase the risk of entry for bacterial infection. So it should be treated as soon as it looks like that. So it's not very sightly. So when we see patients like this, we definitely start treating them for this, and then look for other signs. A lot of times they come in for bacterial infection, and they have to that looks like this. And so that's the most likely source of the bacterial infection is this entry point, and then we'll treat this in the bacterial infection before. All right, so these that we just went over are group of fungal infections. So the physiology of the fungal cells is a lot different than bacterial cells and than our cells. And so this allows us to treat with different types of medications that don't cause excessive harm to our bodies. So they differ from bacterial cells and host cells. And so we have to use antifungals and not antibiotics because that won't treat this. The fungal cells are eukaryotic cells. They have rigid cell walls made of chitin, and the cell membranes contain ergosterol. And so that's what the drugs mostly target. And so that's why we can target these types of cells rather than our own. And so our own cells contain cholesterol and not this ergosterol. So that's why when we give antifungals, it doesn't harm us. So there's different types of drugs that act on fungi, and they have different mechanisms of action. So the ones that we're probably most familiar with are the azole antifungals. Terbinafine we use a lot. Flucytosine we use more in like cryptococcal meningitis, which we're not going to be talking about at least in this fall. We'll talk about that in the spring. And then grignotolvin, we'll talk about later. So there's just different mechanisms of action, but these, we'll talk mostly about the azole antifungals. They also the cell membrane permeability, so they don't allow the cell to be functioning. And then flucytosine blocks nucleic acid synthesis, so it doesn't allow the cell to replicate. And then grignotolvin disrupts microtubules function, which disrupts the cell and its replication processes. We don't need to know this for this estimate. All right. So miconazole or tolmaptate powder can be used in certain areas to prevent infection. You want to make sure you dry areas completely. You can even use like a hair dryer to dry the areas and apply the powder. Making sure there's a lot of areas where you have like bulges of skin, especially in like obese populations where you want to make sure that areas are dry and you can apply these powders to keep from getting up on the infection. That's like those moist environments as well. They really can. We already kind of went over a lot of these agents. So the topical azole antifungals we've already talked about. The mechanism of action. They're effective against P's that we talked about. Proporis, and Cetus. They're also effective against cutaneous candidiasis. And so, I don't think we're talking about that today. And so, mainly the fungal infections that we're talking about today is what we're going to focus on, especially for these things. So dosing, which you don't need to know specifics about dosing, but basically be able to read the box of an antifungal 1 to 2 times per day for 2 to 4 weeks, and at least 1 week after clearing. The one thing that you need to know about antifungals is the treatment's a lot longer than antibacterial or an antibiotic, and so these are treated for 2 to 4 weeks after at least 1 week after clearing. So if a patient clears after say 2 weeks, then you're going to want to treat for at least 3 weeks. And so it's a lot longer treatment for patients, and we need to make sure that they understand that because a lot of patients think that that's a long time, and it is, but it takes a lot longer for the intensive side. We don't want to use with pregnancy or lactation, and we also want to often drain due to hepatic failure. It can cause itching, irritation, and stinging. These are really low and usually mild. They can go away, so if it's severe, then we can try to do it. Definitely might do something specifically. Ketoconazole or Nizoral has a sulfite component in it, so if the patient does have a sulfite allergy, then we would avoid that product. This is just a table of topical antifungals. You don't have to memorize the names or the brand names like that. The ones in bold are the ones that are more commonly used. And Myconazole is probably more commonly used as well. But both Nizoral and Ketoconazole are probably the most commonly used. The topical allylamine antifungals, we use that a lot within the teeth area. The mechanism of action there we talk about inhibit saline oxidase, that's a key enzyme in the erythritol formation of the cell membrane. But it can cause burning, irritation, and this can allow for a shorter course of therapy, but it still does twice a day. And terbinafine comes in both oral and topical form, so sometimes we'll give these as like oral tablets. So that's used most often. I've never seen a naphthalene used. Almost always used as terbinafine for all of our patients. Zirconium, again, we already talked about the mechanism of action. With the microtubules, it's fungistatic, so it doesn't kill the fungus, it just stops it from replicating more. The adverse effects are fairly similar to almost every drug you take, nausea, vomiting, diarrhea, but it can cause photosensitivity. So again, want to tell the patient to make sure that they wear proper sunblock and clothes to protect them when they go out in the sun. It does have an interaction with warfarin, PC9, but you don't have to know that. But it can also decrease level of barbiturate or cyclosporin and the efficacy of oral contraceptives. So that's something that again you want to caution your patients if they are a woman with childbearing age, and they need to make sure that they have a backup form of birth control for the time that they're on medication and for factor. And then they can have a disulfiram type reaction with ethanol. You guys know what the disulfiram reaction is? Like projectile vomiting. So like metronidazole has that as well. So disulfiram is a drug, and you can use it for like alcoholics to not drink, but it causes projectile vomiting, and so they say like patients with metronidazole that we like are supposed to consult that they shouldn't even use like mouthwash, but it's not that common that they look at that, but we do have a lot of patients not to drink while they're on metronidazole. So you'll probably hear that a lot with the drug disulfiram. That's what it means. We have a few more slides on this, so we can take a break. So the systemic allylamine antifungals, terbinafine, again, the same mechanism of action. Like I said, we use it in the treatment with the nail fungus. Because it's For fingernails, we're going to dose for 6 weeks, but if we're treating toenails, we're going to dose for 12 weeks. I don't know. I don't know why there's like that big of a difference between the fingernails and the toenails. I don't know if there's a difference in like how long it takes to regrow them or something like that. Like that was my first thought, but I'm not sure the mechanism behind that or like the biology behind why there's this doubling in the duration. But there is a difference in the dose between, there's not the dose, just the duration of therapy between whether or not you're treating the fungus of the fingernails or the one interesting fact is that you have to check LFTs prior to therapy and at 6 to 8 weeks, especially if you're on the longer therapy, because it can cause an increase in LFTs. And it can cause drug interactions with cimetidine, which is available as OTC. So you need always to make sure you ask your patient what other medications are on and get an OTC product for drug interactions. Then the systemic basal antifungals. So these inhibit the interferon in the membrane. And they are lipophilic, so they have a high affinity for that keratin. So they accumulate in the hair and cells, so this is why they're good for treatment of this. And they have a long half-life, so what they call post-dosing can be feasible. You don't have to use traditional dosing. So we're not even going to talk about the dosing for that. If you want, you can look that up within your drug reference. But systemic therapy is required for TA capitis, minimum for the male one. And then this has a 3A4 interaction as well, so you want to make sure that if the patient's on those drugs that it's not necessarily contraindicated if you have those interactions. You just want to make sure that you dosing appropriately or investigating your other medications based on the levels. And then avoid use in pregnancy. Most of these drugs have hepatic interactions that can cause elevated LFTs. You want to make sure you're monitoring those patients. And we talked about drug interactions, and then it has reduced absorption when taken with antacids and H2 blockers. So we want to make sure that we space those drugs out, especially if like a lot of patients will take like that over the counter every morning, or there might be like on methadol or something. Make sure that we space those out from these drugs. So the systemic antifungals that we most frequently use are fluconazole or itraconazole. We'll go through these next few slides.